Okay, so yep, I'm going to talk about breast MRI by RADS. The reason I put almost is because this hasn't been released yet. So some of this is hot off the press, but not published yet. And my wife Janice Sung is actually on one of the update committees with Steve Poplock and Sally Friedewald and Tula Distonas. I want to acknowledge Carol Lee, who's obviously been the head of BIRADS for different committees for many years, and she's always provided a wealth of information in our group on BIRADS information. So we know that BIRADS obviously stands for the Breast Imaging Reporting and Data System. And it's been, lots of other specialties have incorporated lexicons now, and the BIRADS, and there's LIRADS and PIRADS, and for prostate and liver. So it's been an important step in radiology. I remember I joined this private group back in how long ago was that? 20 years ago or 25 years ago. And I remember seeing the reports were in a mammogram, and I remember one I liked. It said there's a condensation in the upper outer quadrant. So there was some novel terminology used. And so really this was meant to help standardize the terminology in reporting and to improve communication, because the biggest problem with mammography had been the referring physicians getting these reports and not really knowing exactly how they needed to act upon that. So it really added some communication aspects to both the patients and the referring physicians to shore up those cases where, it's left the provider not knowing exactly what to do, and maybe they don't do the biopsy and then there's missed cancers. So that was done by creating the structure to the report, the lexicon for findings, final assessment categories, and then obviously everybody loves auditing, the guidance for auditing. And you have to remember that there aren't, it's not black and white, the lexicon. There's descriptors that obviously are more suspicious and less suspicious, and you incorporate your description using the lexicon to create this descriptive report of your findings. But ultimately, you're the one who distills that down. It's not a formula. You have to distill that down and decide based on the findings. But, so the whole concept of the lexicon is ensuring that the reports are clear and concise and standardized. I've, knock on wood, been involved in some medical legal cases, and people try to hold, the radiologist's use of the BIRADS for that particular case, that they did something, and I bring back in the defense of that in those situations. It's clearly written in the BIRADS and in the ACR website that it's not meant to be used to dictate management on an individual case. It's generalized. It's a suggested standard method, but it's not mandated on a particular case, because each case is unique. And so we've seen over the years the different editions from almost 30 years ago. The start of the small group who started the BIRADS, and now it's grown. The last edition was in 2013, and you can see the number of clinical images has dramatically increased to almost 800. So there hasn't been, the last edition is the 5th edition in 2013. It's electronic and print versions. There have been supplements. So we've seen the guidance supplement on DBT and a guidance supplement on contrast-enhanced mammography. And now in progress is the 6th edition, which is going to try to unify, and I'll talk about some of the changes, unify the terminology between the mammography, ultrasound, and MR. And I think those individual committees have finalized their submission, and now it goes to the cage match of what finally gets sorted out. And so it may take, I'm guessing, at least a year until it's sent for, then the ACR has to get it ready for, publication and, worldwide, distribution, et cetera. So, I think at least a year until we see that starting the process. So again, I mentioned there's the tomosynthesis guidance supplement for tomosynthesis in 2019, and then the contrast enhanced mammography supplement published in 2022, which our group had a lot of input because we've done a lot of contrast enhanced mammography, and so it's funny. My wife has these regular, like around 8 p.m. these Zoom meetings with the rest of the committee, and I'm usually cooking dinner, and I can she's on the Zoom, and I can hear them talking about debating, and I have to bite my tongue from like chiming in. I'm like, no, don't use that term, but. You all know that you can get these pocket cards, these laminated or these cards that we have in our reading room for residents and fellows that have the basics of the different mammography, ultrasound, and MR descriptors. So let's just go over some of the BI-RADS basics. We have. Your thinking should be when you give these categories, again, you use the descriptors, but then you kind of have to use things that from the established data, like we have the Ed Sickles UCSF publication on an incidental. BI-RADS 3 is very specific. It was created for incidental, in a baseline study. It's not palpable, some incidental low-density circumscribed mass. It's not a cyst on ultrasound, or a little cluster of punctate calcifications. That was the only original use for BI-RADS 3 category. It wasn't for, if it's a new mass, all bets are off. It's a palpable mass that didn't fall into that category. So we know if we look closely that it's margins are 85% circumscribed, then that can be safely given, it has a less than 2% chance of malignancy. So, but you can see for a suspicious category, let's say you have some heterogeneous calcifications, it's a big range, 3 to 94%. And then obviously BI-RADS 5, we try to limit BI-RADS 5 as much as we can because it's really got to be, okay, this has to be removed. This is definitely cancer because we have some irregular mass and it gets biopsied, it comes back, fibrosis or, and the surgeons, unless we change the report, the surgeons are always contacting us, I have to excise this. Is it really a BI-RADS 5? So we tend to limit that. But so you can see this big range from 3 to 95. We don't, obviously there's an optional subdivision. I don't know how many people here use it, but you can give it, a sub, because of that large 3 to 94% range, you can help the referring physicians and have a little bit better sense of, or actually the person doing the biopsy also have some clue of where you fall a little bit more divided, and so you could use 4A, B, or C in your categories. How many people here use 4A, B, or C in there? Oh, so maybe about half, more than half. I think it's useful. So obviously 4A is going to be, upper limit of 10%. For 4B, it's about 50%. And C, you think it's not quite 95, but it's above 50 to 94%. But again, that's optional. And so we'll talk about now, so we'll go over what the updates from 4 to 5, and then I'll talk about the planned updates from 5 to 6 versions. In the MR category world, we removed foci and stippled, because stippled is really part of the background parenchymal enhancement pattern. We added breast density descriptors and added the background and it's uniform with the other things like contrast. Mammo was also added similar BPE as minimal, mild, moderate, and marked. That should be at the peak. There's been a lot of debate about when, but that should really be at the peak. The sequence of the peak enhancement when you describe BPE. Non-mass-like was changed to non-mass enhancement. Ductal was removed and just used linear for both ductal and linear, and then added clustered ring, which I think was a little bit, I don't know, novel, maybe not so useful. And so we included the new BPE for the 5th edition, and obviously here minimal, mild, moderate, marked. I have to say at Sloan Kettering and Carol Lee published some of our data on how, we've always used to time our screening MRs contrast breast MRs for cancer screening based on the menstrual cycle. And, there have been her publications, other publications that said that the outcomes, it really didn't change things. I have to say, I think if you can do it, when because these are elective, screening exams, that I would still continue to try to do it during the best optimal time is during the second week of the menstrual cycle, because, it just makes your interpretation harder. Maybe the outcomes aren't all that different because we've gotten used to what background looks like, and you can say, yeah, this is probably background, but it sure adds some anxiety to the reading, and you got a lot more to look at and decide, okay, I think this is all background. So I personally, even though we don't do it anymore, I think I would opt to do it. And so this is just normal enhancement related to the, now this is your post-contrast if this is your peak, really, and it's just related to normal fibroglandular density enhancement. So what's some of the terminology that was deleted in the 5th edition? We got rid of foci and focus of enhancement. So that's a unique focus of enhancement remained. And, here's just scattered foci of enhancement. Most people don't get this because you're too young, but I used to call this the Don McLean pattern. Does anybody know the song? Starry, Starry Night? Okay. I'm showing my age, but when I was at UCSD with Mike Middleton and we started up breast MR, and we'd see these patterns with all these enhancing foci. We at the beginning, we gave a lot of them BI-RADS 3. But now we know that's, if it's, the whole premise of, is there anything unique to the pattern? And when you see, if you're going to biopsy one and there's 4 or 5 that look the same, then it's not unique. So when you see the scattered pattern, or if they've had radiation on one side and it's just it's a BI-RADS 2 pattern. So that's why we don't really need foci, because it's plural. And if it's plural, it's just part of background. And it's normal BPE. And then for mass, this is interesting. We've tried to unify the descriptors from the mammographic lexicon. So we have the round, oval. Well, they removed, I like lobular or lobulated. That got removed, and it was just put under, I don't think a lobular mass really fits under oval, but that was the 5th edition. And surprisingly, I think there's some effort. I don't know if it'll happen in the 6th edition to bring lobulated back. So we'll see if that happens. And then I remember Liz Morse, when she was working on the 5th edition, asked me a question about, they were how to do this. Is it smooth or not circumscribed? And I said, it should just be circumscribed or not circumscribed. And that's what she adopted. So it's either circumscribed or not circumscribed. If it's not circumscribed, then it's then you can have other descriptors such as spiculated, irregular, et cetera. But really, the key, decision whether it's more likely benign or malignant is whether it's circumscribed or not. Here's some examples. Obviously, this is pretty circumscribed, and this has some part of it that's actually not circumscribed. So you really want to use it has to be a high percentage, or 90% of the margins that are smooth, to categorize it as circumscribed. Otherwise, if it has some irregular parts to it, then it's going to fall under not circumscribed. So what about some of the deleted terminology for internal enhancement of masses? Well, we got rid of the enhancing internal septations, and we got rid of the central enhancement. So we only use homogeneous, heterogeneous rim, or dark internal septations. For non-mass, we got rid of ductal and kept just linear. And then for the internal enhancement, we got rid of stippled, and we got rid of this reticular dendritic. Most people didn't use that. So we have homogeneous, heterogeneous, and clumped for non-mass enhancement. And then we added clustered ring, which I think is a difficult term, because you have to be, I think for using clustered ring, you first have to have suspicious focal non-mass enhancement. And then if it has clustered ring, because you see a lot of people are fibrocystic, and they've got kind of that ring, fibrocystic-y rim enhancement pattern. So I think you have to be careful with that. So here's just the example of of clustered ring, where you have these little punched out areas in the non-mass enhancement. And then, so what else has changed? There was clarification on the final assessment categories, the use of the final assessment. I think this has always been debated, but if you look at the original, the last edition for BI-RADS for the use of BI-RADS 0, I personally think it's appropriate. The patient had an MR last year, down the street, or it's accessible, and you have some finding. I would tend to give it a BI-RADS 0 and say obtain. You might want to say if that's not obtained, then biopsy is needed, et cetera, for the finding. But they discourage the use of the BI-RADS 0 to get previous studies. But it's a place you could do it. But also they use BI-RADS 0 for, let's say you see some finding and you want to do a correlation with ultrasound or mammogram to confirm. Let's say it's fat necrosis or a lymph node. But you do need to put in the recommendation, if that study is negative, what should that person recommend? Because the ball can get dropped if you say there's a enhancing mass or a suspicious mass, recommend second look ultrasound, and then that person, it's negative, and they just say, no suspicious findings, you've left the loop open. So you really need to put a recommendation on what should happen after the targeted ultrasound. And so another question that comes up sometimes is the BI-RADS 4 in patients with the known cancer. And also, again, as I mentioned, for the targeted ultrasound, in this case, ultrasound was recommended, and suspicious mass, and then recommended targeted ultrasound prior to biopsy. It's only to determine if it can be biopsied, under the ultrasound guidance, and then if not, you would have to say, oh, okay, then MR biopsy if not seen on ultrasound. And then, so you always have to be careful. You want your management or your assessment category to fit with the lexicon descriptors. Now, again, the descriptors are general. There's obviously some which are like automatic biopsy. Linear non-mass enhancement has a 33% PPV of biopsy. So if you say linear enhancement, you need a biopsy. Or segmental linear non-mass enhancement has about over 60-something% PPV of biopsy. So those findings are fairly automatic, but you need to be careful that those descriptors match. You wouldn't say segmental clumped enhancement and BI-RADS 3. So you have to make sure that those categories match. Your level of suspicion matches your final BI-RADS assessment. And so this is I think, an important change from the early editions to the fifth editions, that the assessment and the recommendations have been uncoupled. You're no longer, strictly mandated to, if you have a BI-RADS 3 to say 6-month follow-up, or you have a BI-RADS 4 that biopsy, because there's certain situations. So let's say an example, a patient has a suspicious finding on MR, it's given a 4, but the ultrasound's negative. Your ultrasound report isn't 1. There's based on the findings of the ultrasound, there's nothing, but we know that the patient needs a biopsy. So your recommendation in your report, even though you have a category 1, is recommending an MR biopsy. So there's other situations where you have particular reason to like it's a BI-RADS 3, but then patient wants a biopsy. So in your recommendation, you would put biopsy because the patient prefers biopsy at this time, et cetera. Another thing, if you have, let's say, a patient who had surgery and you do your MR and their margins were positive. So, but the MR finding looks like just classic post-surgical. You would give that a BI-RADS 2, benign. But then in my recommendation, I would say, benign post-surgical changes. However, management should be based on the results from the recent lumpectomy, the pathology results from the recent lumpectomy. And again, what if you have this big cancer and there's a complete imaging response? So there's no there's no suspicious enhancement. Obviously, we would use a known cancer, even though you don't see any imaging findings. The patient has a diagnosed cancer that hasn't been excised or removed. So that would be a BI-RADS 6. Now, this gets a little tricky. Some people wonder, when do you do a 6 versus a 4 or 5? And there's no standard for this. I generally use if the there's a known cancer, then there's a lesion that the surgeons could just take a little wider margin, and that's generally within about 2 centimeters. You can say, okay, it's anterior or posterior, or inferior, et cetera, to the index lesion. Once it gets outside of 2 centimeters, then I think that turns it to a 4, because you don't want them to make a big surgical defect if it's not definitely a cancer they need to excise. So then we would recommend additional targeted biopsy for extended disease. So then that would turn it from a 6 to a 4 if there's something actionable that would change management, but not something that's right near the margins that they could excise. But again, there's no standard that I know of for when people do that. And so here's some slides that, thanks to Wendy D. Martini, about the changes to the 6th edition, which are likely to occur but aren't completely finalized. And some of those changes include changes to the section like clinical information and comparisons, adding some structured clinical information, why the scan's being done, the acquisition parameters, now that we have abbreviated MR and we have full MR, so they've expanded and revised that section. And then we'll talk about the lexicon things and then the reporting aspects, what I just mentioned in terms of when to use 4 and 6, et cetera, in a known cancer. So under the acquisition parameters, the plan is to add some standardization into what type of scan was done. Was this a full protocol, and that should have at least a pre and 2 post-contrast sequences, or was this an abbreviated where it's typically less than 10 minutes, but there's only 1 post-contrast series, and also if you included some of this ultra-fast scanning, as we mentioned earlier today. And previously, previously was the initial post-contrast sequence. Now we just call it the peak series, which should include that 90-minute peak of where we expect cancers to enhance. So this has been in the works for a long time. The whole use of focus, versus isn't it just a small mass? And that's where we used to have these. What was it? UBOs, unidentified bright objects, but the premise back, we had focus back when people were scanning at an in-plane matrix of like 256 by 256. So we just didn't have enough detail to scrutinize, so we called them a focus. But now with our resolution, it's really time to really do away with focus and just have it as a small mass, right? If it's some unique small mass, then you're going to treat it just like a 4 millimeter mass as you would a 6 millimeter mass. So I think that's going to happen. We've added, they're adding T2 signal intensity descriptors. So it's either hyperintense, so it's like a cyst or a lymph node, but it's fairly subjective, or it's not hyperintense on T2. And that's kind of what we do on ultrasound. We have the reference as, to gland, is the lesion bright or hyperechoic or isoechoic or hypoechoic. So T2 hyperintense, here's looks like a fibroadenoma. It's circumscribed enhancing mass. It's bright on T2. It's oval, circumscribed, homogeneous enhancement, and that generally fits that BI-RADS 2 category. Obviously, if it had washout or something, or internal enhancement was not homogeneous, you would change your category to biopsy. But that's the classic fibroadenoma. Now, I would say that most fibroadenomas don't fit this. When I prepare talks and case reviews and you try to find a perfect fibroadenoma, it's pretty hard. Most fibroadenomas, because they degenerate or they hyalinize, they lose some water content. So they're not always, those tend to be not bright on T2, but then they have very low level enhancement. They don't the lesion doesn't even completely reach like a 50% threshold. So there's a varied appearance for fibroadenomas. This poster child case is pretty rare, but it adds, the more T2 intensity, other than a mucinous carcinoma, adds some level of reassurance that it's more likely a benign finding. The lexicon is going to include some aspects, descriptors of intramammary, axillary, and internal mammary lymph nodes. Axillary nodes, again, it's fairly subjective in terms of, you can't use kinetics for lymph nodes in terms of suspicion, because all lymph nodes have a washout pattern, just normal lymph nodes. But obviously, it's subjective appearance. Really, in patients with a cancer, you really want to look at both sides, and you don't want to call nodes that look a little irregular, but that's how all their nodes look. Versus, does one stand out? Does it have eccentric cortical thickening, or does it have loss of the fatty hilum, or it's become more rounded, et cetera? Internal mammary nodes, you can see probably in about 25% of patients. If you look closely, there might be a 2-3 millimeter little internal mammary node. It's only when they start bumping up about, in a patient with a known cancer and they're over 5 millimeters, they're not flat, they're rounded, things like that. You start to put in the report that there's a prominent internal mammary node. Sometimes you're kind of left with it, of uncertain significance, but they have to kind of factor that into their treatment planning. Sometimes if it's big enough, a centimeter or more, they may get a PET CT to confirm that it's hot on PET. And I've done actually several, not maybe knock on wood, 5 or 6 in the course of 10 years at Sloan Kettering, where they've had an abnormal internal mammary node on a patient who was treated years ago, and now they've potential recurrence. So I've done second look ultrasound and targeted them with FNA, obviously not a core, but FNA of internal mammary nodes, because they want to see if it's the same biology as if they're of their original tumor, so they can plan therapy. So occasionally, but you have to be, there's not a lot of room. You got to be very, very careful with those. And then the reporting system, as I mentioned, that they don't, this is where, when do you change from a BI-RADS 6 to a 4 or 5? When you have, they discourage the term satellite. I like, everybody knows what that means now when you say there's a cancer with a possible adjacent satellite. But so here, if it's, they may try to standardize what I mentioned before about being, fairly close, where it can just be included in the excision without having to do more, like another MR guided biopsy, et cetera. And if it's further away, or it's going to change management greater than 2 centimeters away, then you opt from a 6 to a 4 or 5. And then I think these benchmarks from the original BI-RADS assessment, for the auditing, I think this is high, that your program should detect 20 to 30 cancers on your MR. I mean, once people get, that's, on maybe the prevalence round screen, but once patients start getting heavily screened, that, you're not going to see that high of a percentage. But the other auditing benchmarks, obviously PPV of biopsy should be between, what we see with mammographic biopsies, 20 to 40%, et cetera. And so just to wrap it up here, we've talked about the whole premise of BI-RADS, which I think it's really made our subspecialty stand out, where we have concise reporting, standardized structured reporting, and the referring physicians really know, when they should biopsy and when and what to follow, et cetera. So I think we've really stood out and led the way. And so the newer BI-RADS is really going to try to continue to standardize the terminology even more so across the mammography, ultrasound, and MR categories. Obviously, in terms of the background, PPE, and breast density, we've removed some confusing terms, et cetera. And I hope lobular or lobulated comes back. And so some of the proposed changes from the 6, again, these are all preliminary, but adding the indication, is this a high-risk screening? Is this a pre-op MR, et cetera? Expanding to distinguish now, is this a full or abbreviated? And removing focus and just calling those small masses, and then having a T2, is it hyperintense or not hyperintense on T2? And then kind of some direction on extended disease, when to use 4 and 6 categories. So I think that hopefully in the next year or so, we should see that coming out, but not drastic changes, but minor improvements. Thank you very much.